Hi, Dr. Nan.
How are you?
Good.
Good. So we have a few questions about the Schroth method, and it's in this application with scoliosis.
Make sure you're recording.
Yes, we're recording.
Mhm.
And so we have 40 minutes just to, because I didn't use the CUNY to
Oh,
create the
okay.
video.
I mean, I have the long version, so in case you want to flip over, just let me know. But we'll try to run it as quick as possible if you'd like.
Okay. So does anyone want to start with some questions?
I was thinking maybe like a brief description about what the Schroth method is.
Okay. So the Schroth method is specifically for, it was developed in Germany, and it's specifically for idiopathic scoliosis, which means it's for adolescents who develop scoliosis. And it is geared, it has a manual concept. It uses breathing to support the expansion of the collapsed part of the spine. And it uses your muscles. So you use isometric type of muscles to bring the chest back.
Okay.
So if you want, let me see if I can put, can I share my screen? Am I allowed? No.
Maybe if I give access to everybody.
So if you go over my name, you can make me the host and then I can share. So where it says mute and the three dots.
Yes, I made you a
So
host.
I'm the host. All right, so let me see if I can pull it up now. Okay, so you could see that?
Mhm.
Okay.
Yes.
So basically, it was developed in Germany in 1986, and it is now called International 3D Schroth Scoliosis Therapy. So that is the new name. And this was my instructor that I was trained under. So sometimes I will email him with difficult situations or patients. These are other resources or courses. There is a website specifically for Schroth trained physical therapists. So you have to be trained in order to provide this type of manual type of therapy.
Okay.
Basically, when we do the assessments, we look at the progression rate. So essentially, you want to sort of understand at what level of deviation the person is at, meaning that if you look at the riser sign at the bottom, the riser sign is where the pelvis is. So basically, if you're at 1 or 2, then that adolescent has a lot of growth potential, which means you as a therapist can make the most optimal change. As the riser sign goes beyond and you have more maturity, in other words, you're at there's less growth potential, you as a therapist also have to understand you will have less optimal change. Okay?
Okay.
So that's where the riser sign is. So we usually think of this into our treatment plan. So it's a 3D scoliosis. So basically you look at the following. You look at the coronal changes, which means that the rib cage actually rotates.
Mm.
And then there's a sagittal plane, which means the rib cage actually shifts as well. So because of the coronal shift and the sagittal shift, we as therapists using what you will see later, our manual, we will try to reshift that rib cage to as midline as possible. Okay? So here are the changes. So essentially what happens in scoliosis is at the thoracic spine, the vertebrae actually anteriorly shift. And so you have a hypokyphosis. So they say that when you see an adolescent child and there's a flat back at the thoracic, that puts a potential risk for shifting of that vertebrae. Okay? So as they shift forward anteriorly, now they can rotate. So, and that's what happens at that thoracic spine. At the lumbar on the other side, that vertebrae actually posteriorly translate, and that opens up and then shifts. So if you think about the spine, you want the thoracic kyphosis because that stabilizes the spine, less of potential movement. And the lumbar curve, that's why we have that nice lumbar curve, it stabilizes. So when you see an adolescent who really is flat back, they're already more at risk. There's a vicious cycle with this, which means there's a trigger. So research tells us that scoliosis or idiopathic scoliosis happens in younger children, happens in siblings. So if I come back here, you see these two pictures. These are sibling sisters that I treated. One was 16 and the other one was 14, and they both had scoliosis. So it runs in families. It's genetics. But no one really knows what triggers this, okay? So once you have, and it could start about 8 years old, so sometimes there's no clear shifting, but it starts very young, and you notice a functional asymmetry. So at that point, that the spine can kind of shift back. Over time, there's actually wedging of the vertebrae. And there's actually morphological changes to that spine and the ribs. So what happens is too, in this technique of Schroth, you have to understand or get a sense how much the spine has changed and what can you or can't you change, okay? Because of this wedging and the change, then that's where the shifting comes in and there's wedging inside. Because of this wedging, sometimes on the collapsed side, they actually have a lower lung capacity because the lung can't expand. As a matter of fact, they have done research that at that point, the alveoli themselves are fewer in numbers. So they can look like they have some asthmatic reactions, but it's because the lung is not able to ventilate, to expand, as well as inside, there's less potential alveolar volume. So as they grow, there's more asymmetry, in other words, shifting of that spine. Hence, I will come back to that picture, and you could see the bottom right. You see how far her curve is, okay? So there's shifting. What happens is then there's cardiovascular restrictions and cosmesis, which means that they now know that they're asymmetrical. And then there's a large what's called distress, because at that point, parents want to find help. They're on the cusp of surgery, and now they're embracing. So this is the vicious cycle that kind of permeates, okay? If you have any questions, just stop me, because I don't want to take too long on each, but I want to explain the overall process. So typically we prefer to have x-rays because it really clearly tells us what we have. When we see an x-ray, we look at the following. We look at the transitional vertebrae. We all have transitional vertebrae, which means from one to the other. When you look at scoliosis, you actually look at the transitional. You see here, this is a transitional where there's a peak change. So there's a transitional at the top and there's a transitional at the bottom. From this transitional vertebrae, there's an angle that is created called the Cobb angle. So when you read an x-ray, it will say the Cobb angle of that child is 30 degrees, which means that is 30 degrees of the spinal curve, okay? Then there's called a central sacral line, which is usually a line that's just drawn all the way down. And that is just an x-ray terminology. Then you will have major curves. So again, the x-ray will tell you that the child has a thoracic curve and a secondary lumbar curve, or just a thoracic curve. So if you look at here, this is the girl up here that I told you. So this is here, right? And I'm just going to go to the top. And the girl here, Zoe, that's her x-ray. Okay. So Zoe actually has a 26-degree thoracic and a 22 lumbar. She's only 14. Her sister, who's 16, her curve is actually doubled. So in 2 years, if without support, Zoe could actually have a 40-something degree curve, because exponentially that curve can grow very quickly. Okay, we do. So under the Schroth, we look at blocks. So once I see the x-ray and once I see the child, I have to decide where the blocks are largest. The blocks, if you think about it, are the ones that will have to be shifted. So if you mentally think of your spine and you divide it into blocks, those are the blocks that will have to come closer to midline. Okay? So if you look at the top one in blue, you could see that it's actually not only shifted sagittally, but rotated coronally backwards. This one, the yellow one, if you look at it, it is now deviated sagittally this way, rotated posteriorly. Okay? So if you think about the spine as a block this way, when I do my treatment, I have to reshift this block backwards, forwards, and in. Okay? Because essentially you want to use the blocks to visually orient yourself where you're going to push. Am I okay so far, you guys? Okay.
Yes. It looks like with the Schroth method, you also address like the shoulders. It's not only the spine that is being addressed, like also like down the kinetic chain, the shoulder and the pelvis.
Exactly. And you're going to see later in my assessment that I have to assess that. Those are the parts that I can anatomically assess as well. And those are the ones that I will reassess to see if we have progress.
And I have one more question. You mentioned about the Cobb angle. At what degree of the Cobb angle is the Schroth method indicated for?
So typically, I've actually treated, and you'll see later on, I have a 19-year-old who was beyond 45 degrees, who never had surgery. Typically, they will first recommend Schroth, even if it's to not only orient the spine a little bit, but also to strengthen the spine before they do surgery. But 45 degrees is that mark where they potentially want to do surgery.
Okay.
Yeah. So again, here's the blocks. And you could see that on the first one, you see how that blue is very large. That means that is the main block that I would have to address. Okay. So the blocks provide you a systematic approach to figure out where do I address first. Okay. It's a long time to get really good at drawing these. In fact, we draw them so that we can always remember what the person looks like. Okay.
So you're always addressing the largest deviation first, it looks like?
Yes. So typically you will address, especially as they're younger, the thoracic first, because you know that the thoracic is the one that won't change as much once that growth is ended.
Okay.
The lumbar spine, because it's supported with muscles, you can kind of work with that a little bit more. But because the ribs are in the way, once you have those morphological bone changes, it's really, really hard to change.
Okay.
So typically you want to address that thoracic spine first.
Right.
And most of the time, in all of the cases that I've seen, the thoracic is mostly the largest involved. Okay. So these are the classifications, again, very systematic. We all use the same terminology. And this is why we use the same terminologies, because it's easy to understand. We use it for treatment planning. And if somebody who's Schroth trained picks up my written case, they will understand this terminology. It's like a language. So if the thoracic is the one involved, it's called a 3C or 3CP. The P is the pelvis, meaning that there's a curve on the thoracic. And now the pelvis has also shifted. If it's just the spine at the thoracic, it's only a 3C. Okay? If, let's say, the lumbar curve seems to be the largest curve or that largest block, then it would be a 4C or a 4CP. Again, P means that the pelvis has elevated and sometimes rotated. Okay? So this is how we call. This is how we name it. Here's the caveat though. Even if it's a 4C, you always name it by the thoracic. So let's say my thoracic has shifted and posteriorly, but the lumbar is larger, I still will call it a right 4C. Okay, so that's just quick terminology. Okay, so when you assess the child, you want to remember these points. Why? Because your hands are going to go to these points. Okay? Basically, the rib hump is the one when you bend down is protruding. Right? So it's the one that is coming back. That's the hand that you will actually do a lot of mobilization. So you will actually mobilize that side. Okay? Actually, I'm just going to bring, okay, we're going to have the dog. Let's see if it works. The lumbar prominence is where the lumbar came backwards. So there's really a hump, but the hump is from that paraspinal muscles. Again, you're going to use that to do a lot of manual PAs, PA joint mobs, because you want to push down. The weak points are where you're actually going to put your hands and you're going to ask them to breathe into those weak points. The weak points are usually the ones that are collapsed, okay? So the weak point is the opposite. So meaning that if I have a curve backwards here, this will be my weak point. So when I put my hand here, I'm going to ask them, can you breathe into it or push into it? My weak side will be here. So remember my hump is back here, right? I have a hump here. Mm-hmm. This one will be flat. Okay, so I'm going to be flat here and I'm going to be here. Make sense? So when I come here, I'm going to ask you to breathe into it because it's weak, very weak, flat, underdeveloped. So I'm going to go breathe in, hold it, hold it, hold it, hold it, hold it, okay, because it's weak, flat, weak, concave, okay. Anteriorly, you're going to use the front to open up that chest cavity. Okay, so you're going to ask them to breathe into, again, to open the chest and get the anterior lobes of the lungs to expand. Okay. So there's different postures that we talk about. Habitual is what we just stand as. Conscious posture is what we want to develop, which means you're using mirrors, you're using your hands to develop a posture that you are aware. You're retraining this posture. Oftentimes, the children will say, this feels so weird. This does not feel right. Because you're actually reshifting and redeveloping a conscious posture. It's like a relearning process. The correct posture is a normal, which in scoliosis, we never 100% go back to. And then you use daily activities, which means you encourage them to elongate that flat side by reaching. So if they're doing reaching, you're asking them to reach that tight, weak, concave side. Okay? So here's the assessment, and this is where we kind of also use. So you look at the anatomical, the scapula is huge. On the convex side that's tilted, because the ribs come back, it actually pushes the scapula away. So you tend to have a large protraction of that. So you have an elevated shoulder on that side because the ribs are coming back, okay? I usually look at the feet because there's usually a lot of pronation. And you look at the Adams test and the scoliometer. So here, let me show you the scoliometer. So this is a scoliometer, and we usually put this on the spine and we tilt it. And once you have a deviation, you see how it tilts, and you document that. And so you document it each time if there's change. I usually do before and after, and believe it or not, I usually go from 10 easily to 5 in one session. The problem is sustaining that. That's where a lot of repetition. So then we do let me see if it pulls up. I do side bending, because you will have side bending that is, so from the third finger down, okay? So she has a mild scoliosis, and here's me showing. You see how it moved? And I systematically go down. I mentally remember whereabouts that is so that I could try to retest. When you do this, you want to also make sure that the pelvis is stabilized. So sometimes people put the person against the wall. I usually use my leg to stabilize the spine. And the other thing you look at is the ear. So you go from the earlobe to the AC joint, because that'll tell you how elevated or tight there is. Okay. It says unlimited minutes. Is that okay? Okay. Just let me know. You will do a single leg stance because there is weakness. So typically the side, remember how I said concave side here, right? When you stand on one leg on the left side, they can't stay as long, because think about it, your center of gravity is more where that large curve is. So single leg actually is skewed, meaning they don't have the same on both sides. Okay, you will ask pain measures because they do have pain sometimes, and you will ask them about breathing. So sometimes I will test a little bit their breathing capacity, okay, because that is typically affected. Okay, so now let's talk about, this is a 13-year-old girl. She was a swimmer. Her diagnosis was a 42 degrees. I had classified her as a 3C, which means the thoracic on the right was mostly affected, okay? So what I usually do is I have them sit down, and can you see my arrow here? So I can, so you
Yes.
see how here is the tight area? So I use her hand on the wall to stretch. I position my hand here, and I'm working on her scapula. So I'm bringing the scapula back, okay? Then I'm going to incorporate breathing. So I'm elongating here her spine, bringing that scapula back in the right spot. Now I'm going to use my hands to facilitate movement of the rib cage using breathing. And we're talking to each other. So she's breathing into the left. and I'm slowly shifting the spine. Does that make sense? So let me escape and
Yes.
sort of guide you. So I first feel her rib cage, so I get this rhythm. This is the tight area. So I go breathe into my hand. I give her a little input. Breathe into my hand. She breathes in. I let that lung expand. I hold it there. There's that isometric. And then I shift slowly. And we do it over and over and over. Okay? So basically using the breathing helps that rib cage mobility. It helps more of that weak point, because what happens is the lung, as it expands, is actually pushing. So as she breathes in, that lung pushes that side. And I use my hand to facilitate what I'm looking for.
Sorry,
So perfect.
Dr. Sandra. Did you work in each vertebra, like doing this pressure, the joint mobs, or did you work in all of them in once?
Okay, good question. So
Vertebra
before
in the angle, like the makes the angle in each of them, or all?
what happens is at this point, what I showed you is one unit. However, before this, I usually do individual work, which means I actually then do rib cage mobility one-to-one. I will actually push into the rib cage and have them shift. So for example, if I'm here, I will actually shift up and out like this and ask them to side bend. So I'm actually pushing the rib cage in, up, into it, and then oscillating. So there's a lot of manual as well. Okay? And depending on if they're very tight, I will do a lot of rib cage mobility before I come to the breathing, because otherwise I won't have that capacity. Okay? But remember, like most Okay, so here's the 19-year-old that I was referring to. And this was before and after. And this actually was less than a month. And he was 46 degrees and he was actually having a lot of pain. So he had pain 4 out of 10. What I did with him was a lot of sitting and a lot of pole work. So I'm going to show you the pole work that we subsidize. I did very similar, the stretching and the reshifting. And you could see here what a difference. So here you could actually see it. You see it? Here, the spine. And here's more straighter. But here he still had a little bit of compensation with his pelvis. So I had to retrain him to keep that pelvis. Oftentimes, if you could see, this quadratus lumborum on the right is very tight. Okay? So we need to stretch that quadratus lumborum. So
Professor, how painful is the manipulation?
it's not comfortable. It's not usually very comfortable. And sometimes young children don't even want, or they start crying because it is very uncomfortable. But I have to shift, especially the thoracic, because otherwise I know my window is closing in very quickly. But it's only part of the treatment. I have to passively move. I have to breathe, increase my breathing capacity. And then I have to use isometrics, or the poles that I'm going to show you, to create strength. So it's a little bit of everything. Okay?
So Professor, so what you mentioned just now, that's the order in which you go in order to treat a person with this condition?
I'm sorry, can you repeat that again? I don't think I can.
I said what you mentioned just now with the passive movement, and then you said the move on to strengthening and so forth. That is the order you use to treat the patient?
Yes. This is how I use to treat the patient. Exactly. Okay. So there's passive stretching. Oftentimes we use the wall. And for example, so I usually go, okay, let's put the wall. This is my tight, right? My concave side. And then I go, okay, pull, breathe into my hand, pull, breathe into my hand, and I'm really elongating. Okay. At the same time, here, sometimes I will actually push into the rib cage. And then I will ask the person, okay, pull, stretch, breathe. So we're stretching, shifting, sagittally. In, okay? If you notice here in the second, I'm actually, again, shifting the rib cage. So my hands are on the rib cage and I can actually shift the whole rib cage. Okay? Once we stretch, and usually we do everything in one session. We stretch, we breathe, we strengthen. Once there's a lot of stability, then we go into dynamic work. Okay? So strengthening will also improve, obviously, the neuromuscular, right? Because actively you're retraining the brain, as well as their proprioception. So hence here, if you see, I'm using the wall to provide that proprioception. The bean bags can also add proprioception. So oftentimes, at first we use these bean bags in supine or side lying to train them that, for example, so if I'm in side lying, I lay them down towards that convex. And now, not only am I feeling proprioception, but this is like my hands pushing on the rib cage. Okay? And so if they're laying on their side, I can now have them just stretch. Okay, so this is very early on into treatment. Okay, this is early on into treatment. When they're sitting here, they're already doing it on their own. Okay, the poles are strengthening as well as sometimes can be added into dynamics. So I'm just going to get my poles. So here are the poles. And typically, let's say I have a right curve, okay, because it's the most common, okay? Right curve. So remember how I want that shoulder to be back? So my arm is more at 90-90. Okay, this one has to come up, okay? So I'm here, just like you could see on that picture. And then what you do is you incorporate the breathing. So I usually have my hand, or you could have a TheraBand around here, and you breathe into it and hold. Once you're here, now you push down on the poles. As you push down on the poles, it's like an isometric. Okay, it's like strengthening your back muscles. Okay, and we do this. Then you can make it harder for the patients. But remember how I said they have a hard time standing on one leg? So you push and then they have to stand and tap. Okay? So that's some of how. You could use the poles and have them sit on a therapy ball. But the poles are important because it's strengthening and remember and retraining that posture. Without the poles, they have a hard time understanding where they have to shift those blocks that we talked about. Okay? Sometimes what they tend to do is they want to just side bend. They want to do this. That's not it. You're literally shifting a block, which is part of the spine, in, if that makes sense. Okay? And then this is basically just a home exercise program that I have given a patient. So you can see she's doing the sitting, you can see she's doing the poles, and some supine. So what happens is in supine, we again use these, okay, they're like bean bags, we position it to create a spinal alignment that is normal, basically. And then you strengthen the abdominals because they tend to have very weak abdominals. Okay? Normally with scoliosis patients, you do not want them to do sit-ups. It's way too much stress on the spine. So what you normally do is you actually have them usually a lot of lifting up. So in supine, with a corrected alignment, you have them exercise, almost like Pilates. But you normally don't want them to do a lot of sit-ups, even after surgery, because sometimes they'll come to us after surgery as well. Okay, so now I'll take questions and then I'll review anything that you have questions with.
And I have a question. So how many sessions did the patients they need? So, or in order to get like a result,
Right.
like solid result, like, because you said
Solid
before, like it's hard to maintain that decrease.
So usually I will see them twice a week because we're stuck with the medical system that we have in the US, right? So twice a week for about 12 weeks. But what happens is I have patients that come back to me, which means they did well. And then after a couple months, they're regressing. Because what happens is they forget that they're still growing. And as they're growing, their spine might shift again. And if they're not diligent at doing the exercises, the spine's going to go back. Schroth is almost like, you know, when you have a small tree and you pull the tree in the right direction, but if you take that direction too quick, the tree goes back.
Yeah.
Schroth is like training that tree to really align itself just right as the spine is growing. So I have a lot of patients that come back to me after 6 months or a year, and then we redo the whole process.
Professor, does the regression mainly occur in younger patients or older patients?
It's interesting because the younger patients have a harder time because this takes mental capacity. So in other words, I usually have to say, okay, breathe only here, but not your whole spine. So they get very frustrated because they don't have a certain level of awareness and body awareness. And then sometimes this is not easy because the exercises are all angular and they can't understand sometimes what I'm doing. So oftentimes they don't want to do it and it's uncomfortable. So when they go home, they don't want to do something that they're pulling their spine and it's a little uncomfortable. So they are usually the ones that regress the most, and they're usually growing really fast. Did I answer your question, Renelle? I just want to make sure.
Yes, you did.
Okay.
At what point would you have to like recommend surgery instead of the method itself? As in, like, at what point are we like, oh, we can't do the Schroth method anymore. We have to do surgery in order to correct your posture. Like, what stage or
Now,
look?
usually there's a restriction. So means that I feel when I've plateaued. So when I start to feel the spine and we're working it, I usually feel a resistance, a hard end feel, right? That's when I know I'm not going to get more than this. And it's usually very hard because I really don't want them to have surgery, but then I could feel that, you know, like, I can't push the spine. And then when I also know I can't push the spine anymore, and they're already at that cusping edge of the angle, then I usually sort of have to say to the doctor, like, I don't think we're going to have more success than this.
Would you also continue doing this after surgery or? Okay, good. Okay.
Yeah. Yes, because after surgery, remember that they align the spine, but that tightness and that weakness on the weak point is still there. So we still have to realign and strengthen those axial muscles and everything. Because believe it or not now, again, cognitively, they don't know where their spine is. When you close their eyes and I correct their posture or conscious posture, and I say, this is your conscious posture, usually they're like, no, it's not. It feels so weird. So you're remapping where their spine is. And if not, they're going to go back. Remember, the brain has a mapping mechanism. So it's very important that they do re-strengthen. And that's not even to say that, to be honest, sometimes there's a functional leg length discrepancy because the pelvis is shifted. Kind of like you're working, like Daniel said, you're working at all angles down, up the chain. You know, the scapula is still weak because it was out of alignment, so you have to retrain that. It's like there's a lot of shifting that happens in scoliosis.
Professor, I have a question. Can this method be used with other patients, like not only scoliosis, but let's say another patient who might have postural issues?
Good
Because it
question.
seems like you're yeah, especially now that everyone's sitting in front of the computer with a forward head and port.
You know who I find this really works really well is actually the older women. You know, in osteoporosis, there's just changes in the spine, right? And actually, because it's so gentle, you know, pushing down on poles is actually very gentle. And if you do it yourself, it forces all of your back muscles to work. And so what happens is they love it because they're strengthening. But you know how older women, they don't like being on their belly, you know, they don't like the weights. So it actually is a very nice complementary concept. I actually use this actually for also athletes, because sometimes I actually have athletes who have mild functional scoliosis when they're pitching a lot, right? That turning, they tend to have like a functional hump a little bit because they're constantly turning this way. And I actually just kind of do it a little bit for them to know where to align their bodies before they pitch. So I find that it's a nice complementary substance. The other therapists will look at me like, oh, there she goes, getting the poles, whatever. But with the poles, I actually sometimes put a TheraBand in between. So if you put a TheraBand from one to the other, and you actually have to push that TheraBand and pull it away, do you know how much shoulder stability that requires just to pull the poles away with a TheraBand? Tremendous.
Yeah.
So I find it to be a very functional way of strengthening, very mild. I have worked with older women. What happens also as with scoliosis, with that idiopathic scoliosis, is sometimes in older age, it actually gets even worse. Remember, there's degenerative changes. So all of a sudden, they have a larger curve that happens and their pain is pretty severe. The problem with them is, and I have gotten like a little bit of rib cage mobility work, but it's tight. You know, it's like semi-fixed. So I don't have that a lot. But that usually is the problem. I had one older woman who her balance was horrific. She was losing her balance and she had a scoliosis. I trained her, but with this technique, but it was really sort of to improve her balance. Not only did she improve her balance, she was walking longer distances. She was happier, like generally happier, and she was stronger in her back. Curve was still there. So the take home is we may not always, and I have reduced, I actually have had 2 that were candidates for surgery and completely were fine. So they were 40 and they went all the way to 30. So it was intense. But if they don't continue, it can kind of creep back, right? Just like if we're sitting hunched over for a long time, we're going to kind of stay a little hunched over.
Yep. I have one more question. So as a Schroth practitioner, like what other challenges do you see like when applying this intervention on patient? Because it seems like some of the techniques could be complicated to explain to a patient, and it could seem like very time consuming and exhausting between you and the patient.
Absolutely, Daniel, and you hit it right on the nail. It's very exhausting. So usually I tap myself. I can't see a lot because I'm exhausted. And as the spine sometimes shifts, I have to recalculate where everything has to go. I have to figure out a judgment. Should I move on into strengthening or keep on that mobility a little longer? Because once I start to strengthen, I might kind of infringe on it. Sometimes I get frustrated with the rotation. I want more decreased rotation and I can't. So it is very exhausting as a therapist. What I used to do is now I've kind of had to change because people are financially not able to, but I would slot an hour, and they would pay the difference. And I would stay with them the whole entire time because it's very hands-on. You can't really give them a lot of independent exercises. You give them a little bit, but oftentimes it's very one-to-one basis. So that's the challenge. Exactly. The timing of the breathing is important. And sometimes people get frustrated. If you're using the breathing correctly, you're missing the boat. So sometimes even when you train them and you go home, like I have a parent that still comes, each time she's like, how does it go? Where are my hands placement? Time I say, okay, feel my hands. This is what it feels like. But because it's so sophisticated of a technique, it's hard. You're constantly training, educating, review. I usually have them videotape themselves. So I usually say, take pictures, videotape, so that when they go home, they have those visuals.
Okay. Thank you.
Yeah,
So Professor, I have a question for you.
of course.
Is this intervention useful in the orthopedics settings?
Yes. So I usually see these individuals at outpatient. I schedule them in outpatient. I try to incorporate, TheraBand work or TheraTube. So basically, remember that pole? I could use only one, and then we're using other normal exercises. So in outpatient, actually, once they get really good, I've had two athletes. One was skiing. So basically, once she was towards the end of her treatment, we actually recorrected how to ski to keep her conscious posture. So it's outpatient. It's very sophisticated outpatient. I fill out the forms just like any outpatient, and I use the classification that I talked about. And then I put Schroth methodology. I get better reimbursement if there's pain or some kind of other measure. If I am just to put idiopathic scoliosis, usually I don't have as many visits because the research still thinks, oh, it's idiopathic, no big deal. Although there's evidence-based and research supporting this methodology, even more than just bracing. So this has actually been researched to have the best effect. Why? Because it uses the muscles. If you think about bracing is great. You remove the brace, body goes back. Muscles are weak. But here, I'm slowly using the breathing as well as my hands to isometric and the poles to create strength within those areas. So that's why research shows in the long term, this is the best technique.
So Professor, the best device to use is a polling?
Now, sometimes you can use a ladder, sometimes the wall. Again, I have them push. So they push the wall, so there's resistance. So the wall is pushing back, that's the isometric, and they're pushing against that wall. I sometimes use a counter force. So have you ever seen a lot of that side lying that they talk about? So what happens is when they're in side lying, they're pushing onto a stool and they're pushing this way. So you can kind of use different ways. The original technique was using ladders, and again, they push. Okay, but you push down. So you're basically pushing down the ladder or pushing down the pole to create strong isometric contractions along the spine.
Thank you.
You
I have-
usually you start about 15 seconds to 30 seconds of an isometric, and then you want to prolong it to 60. Like a minute, holding it for a minute, over and over and over. Because again, remember the axial muscles are to sustain, not about repetition, but long hold, right? They're type, 2 fibers. So they need to really hold the spine. That's why you hold that contraction as long as possible. And then remember how I said I resist or I use a TheraBand. So they're holding it not only against pushing down, but against some kind of resistance that's giving feedback.
Okay.
Any other questions? I know. Quick as
I have-
possible.
Professor, I have a question. Oh, Ellie Ron could go.
Go ahead, Eliran.
I apologize. Sorry, I'm in whatever outside, a lot of noise. Okay, basically, I read an article about the method, the Schroth method, and I'd like to know what is the purpose of using the mirror?
The mirror is feedback. So remember how we're recreating a mapping and a conscious awareness of your posture? And they have to almost visually ingrain that that's their new norm as we're working together. And oftentimes I will, at the end of sessions, say to them, can you please show me your conscious posture? And I do nothing. And they have to then remember using the mirror what that was. Because if you have to correct your posture, right, like we always do, they have to know where to shift those blocks. And I usually talk to them in that terminology. Okay, we're going to shift this block this way now. We're going to shift this block this way now. So it's the same language that I showed you. It's the same language we use.
Thank you, thank you.
You're welcome.
By the way, I missed your class. Thank you so much. It was an awesome experience.
Thank you.
Professor,
Yes.
are there any interventions that rival the Schroth method? And if so, how do they compare to the Schroth?
At this point, there isn't. There is an Italian version and there's other techniques. They're very similar, so there's overlap with them, but they use very similar concepts of the manual and the resistant work. So there's definitely a couple of them, but they have very similar thoughts. And I don't know
Okay.
the top of my head, but there is. You can actually, there's one large article that I have, and I can forward it to you guys, where it compares all of them, all of the different techniques, and you will see a little overlap between one another. So basically, there's an Italian version. This one is the German version, but they're very similar. This one
Okay.
has a little bit more research, actually, if you research it.
Okay. And also, the Schroth is used in combination with the bracing as well, right?
Yes, the surgeons usually would prefer that because they feel that they cover all the bases. But when they recommend the bracing, it actually has to be worn like 22 hours a day. So typically what they normally, they come home, right? Because they don't really want to wear it to school, right? Because it's sort of like, they're usually 8, 10, sometimes 14, 13. They're not wearing a brace to high school. So they usually come home, they put it on, and they sleep with the brace. So that's how they fill it in. And then there's a lot of different types of braces. Schroth prefers what's called the Schroth type of brace. So they highly recommend that that's the best brace to complement Schroth. But the orthopedic surgeons usually do want the brace as well.
Okay. Thank you.
You're welcome.
Dr. Rivero, I have a
Yes.
question. So does the patient have to meet a criteria before they start the treatment? Or
No, they usually just get a script, no criteria. A lot more orthopedic surgeons now are in favor of Schroth. And this started about a good 10 years ago, Whereas previously, like my daughter had scoliosis, and 20 years ago, it was, we're just going to watch it. And then if it gets really bad, we're just going to have surgery. Now, what happened was Hospital for Special Surgery was one of the leading hospitals that sort of showed that this is a good method. And now a lot of the orthopedic surgeons who deal with idiopathic do recommend it. So the referral will say Schroth. You know, I have people calling me, what's that method you do? The Schroth, what, you know, but they now have the words, and whereas before they didn't even know. But nothing else than that. So there's really no recommendation. The surgeons are quicker to provide this treatment for the patients quicker, because they know that this is a time-sensitive problem.
And also, there is any red flags? Maybe you say, oh, for this patient, I cannot perform this method. Like,
well, what happens is if, for example, someone has, you know, I said idiopathic, right? Because sometimes there's scoliosis that are neurogenic, right? Because of neurological or congenital or because of other neurological problems. This may not be the best because you need cognition. You need to be aware of how to move your body. So with those individuals, you can do a little bit of manual, you can help a little bit of breathing, but you're not going to have the same outcome because they can't understand. Same, if you have a muscular dystrophy patient, they may have the cognition, but because of their muscles being so weak, because of dystrophin being, they're not going to be able to do it. So those are the candidates that are not really ideal for us.
and also, how many weeks after the surgery they can see you, or the orthopedic surgeon sent to you?
So it kind of follows very similar to any status post surgery where they can come to us right away. But the first thing we're going to do is decrease the swelling, the inflammation, tissue manual, right? Because there's scars. We're going to sort of, for 2 to 3 weeks, we're just going to take that route. Then afterwards, we can start to do the breathing and then start to do the exercises afterwards. So it's typically like any other status post surgery.
My last question, sorry.
No, anytime.
During the strengthening phase of this method, so in which muscle like you focus on in the back, or is in all of them that you work?
You kind of use a lot of the back muscles. If you think about it, the back muscles has about 6 inches of layer of muscles. You also use a little bit of the serratus anterior, if you think about it. You use the intercostal muscles because they're actually breathing. You use the rhomboids to stabilize. So you're using, believe it or not, just about all of them. And for example, I didn't bring this, but if you have a lumbar curve, you're actually stretching and strengthening all at once. So usually that gets really complicated. Like I will have, let's say I'm sitting here, I'll actually have this hip down so it stretches while there's a pull here. So I'm actually working on the 2 curves. And here at this point, I actually will rock the pelvis, and actually then they will push down. So they use their quadratus lumborum to push down actively. And while they're using, so believe it or not, you can use a lot of muscles. But in the thoracic spine, you're using all of those intercostal muscles, all of the back muscles, even the small ones that go from just a couple of vertebrae. Because remember, there's a shifting, so they have to shift.
Thank you.
You're welcome. And sometimes, believe it or not, you will even have a curve up here in the cervical spine. Remember that the body always wants to be straight, and it will start to turn on itself until your head looks like straight. So sometimes you'll actually have to do some manual work, also the upper traps and the scalenes, because what happens is if I'm here, right, the neck comes here. So now there's a shifting of the spine. So there's a lot of just work of strengthening. You know, you work on your lats, again, the depressors of the scapula. You also do work a lot on the subscapularis muscle, because sometimes it's an entrapment that happens, and then there's pain because the subscapularis is weak and then not able to stabilize. So there's a lot of scapular muscles, back muscles, ribs, rib cage, intercostals, and then you actually, believe it or not, indirectly work on strengthening the diaphragm itself because you're using the diaphragm. So, believe it or not, sometimes with scoliosis, you'll even have the jaw that is not in alignment. So you will notice that too. So if you look at their jaw alignment, it's not aligned because the pull. Remember, the neck will pull and the maxilla will be shifted. I wish I could show you the hands and like let you feel what it is, because then it would make total sense. But I know it's in this format, it's a little hard. Did you get a sense of what this is about?
Yes.
Yeah,
Okay.
And I particularly like how the Schroth method takes like a holistic approach, starting from like the top, the scapula, down to the spine and the hips, trying to correct.
Absolutely. I feel like it's a very holistic, gentle, but strong approach. It's very individualized. It's individualized for the patient, and the progression is individualized, meaning that if it's a very young child, I have to spend a lot of time at the beginning, that body awareness, the manual skills. If it's an older, like a 19-year-old, I can jump in faster because he has more awareness of his body. So again, I tailor it very differently depending on who it is.
Quick question. I'm just out of curiosity, us as like future PTAs, are we able to be certified in doing this too, or is it just strictly?
Typically, you can be certified. Anyone can be certified. It is costly. It's over $2,000 to be certified. Now a lot of the classes are sort of like overseas, or you have to find the classes. That's why I can send you guys the links so you can see it. And usually, I believe it's still the same. You have to take the labs and then you have to take sort of a test. So basically, we had to take a test, and he came around to make sure that your handling skills were fine, your rationale for what you were doing was good. So I believe even at your level, if you want and you want to invest the time, you could certainly be certified. Yeah, there's Schroth trained therapists worldwide. So this is not just US, worldwide.
They are certified.
Any other questions?
How many Schroth certified?
Hold on, say that again.
Sorry, how many Schroth therapists are certified?
Actually, if you go to the US listing, you will see it. They're not a tremendous amount. There are a little across the nation, but believe it or not, there aren't as many as one would suspect. I don't know off the top of my head, but it's not, a lot of people want to do it, but they don't want to invest the time in actually getting certified. And they also know that it's a one-to-one, which means that if a lot of therapists are thinking about that productivity or just making money, this is not exactly going to make the most. It's something that is very specific, very, very narrow patient population. And like Daniel said, it's a lot of work for the therapist. It's a lot of intense work.
It sounds like only a therapist that sincerely wants to do it is that type of therapist to do it.
Exactly. I mean, and believe it or not, it's actually very emotional. So I've had children or young girls cry because all of a sudden they don't see themselves perfect because they have actually a curve. So or the parents start to yell at the girls because they're not doing their exercises. And I'm in the middle like, oh, this is so uncomfortable. So then I sort of have to be that like the mediator, or I have to boost the girl's confidence that just because her spine is not exactly perfect, that doesn't mean anything. So again, it's a very complicated type of treatment, very complicated. You know, or then, you know, the parents will come back after regression and the parents are usually very angry. It's like, they didn't do their exercise. Now I'm back and I have to do this again. You know, like, okay. So it's that kind, yes, you're right. You have to be invested in this for the right reasons. It took me a very long time to feel competent. So even after I did the course and I had my first patients, I felt a little insecure. It took a long time of practicing and practicing to feel really competent, even after I did the course.
Okay.
Anything else? Mm-hmm.
Does anyone have any more questions?
No?
So I guess, yeah, that concludes our meeting. And I want to thank you again so much for taking time out of your day
Yeah,
to meet with
especially at the
us.
last minute.
I know.
That's okay. I mean, I know Hegi was one of